It's very important to, when we talk about PCOS and the types of PCOS, and when we say the most common type of PCOS is the insulin resistance PCOS, we need to discuss insulin resistance, because let me tell you that they are Batman and Robin. You cannot separate them today. The minute insulin starts to cross 7, the patient is getting into, so 7 to 10, mild insulin resistance, 10 to 15, moderate insulin resistance, above 15, high insulin resistance. That's how you look at insulin resistance. Polycystic ovarian syndrome and insulin resistance are deeply interconnected. So if you see, you can't get, it's a cycle and cycle. I'm saying there's a question I can read which says, shall we recommend low calorie 1200 to lean PCOS? No. First, you have to know that the lean PCOS, do they even have IR? So most lean PCOS, as I've explained, probably don't even have insulin resistance.
Hello, thank you for tuning in. If you want to come back to this video later, just tap on the like button. It will save it to your liked videos, so it's easier to find. And don't forget to hit on the bell icon to get notified whenever we drop new content. Stay curious, keep learning, and see you on the inside.
Good evening, doctors. Welcome. And I know that each of you in your practices probably sees this every single day. Sadly, I would call it maybe an epidemic, but PCOS and insulin resistance exists in common in women very commonly these days. And I remember maybe 25 years back, we wouldn't see so many cases, but now it's absolutely, it's like just a bit off the normal that people consider, oh, you have PCOS and its presence. So it can lead to many complications, can lead to many other issues. So I think it's a relevant topic to discuss and see if we have anything new with it, or to understand it deeper, and to be able to help so many young ladies, older ladies deal with this issue. So I wanted to start. We all know that it's the other name for it is teen Leventhal syndrome, and it affects women during their reproductive age. It can have irregular menstrual cycles. It could have excess male hormones or hyperandrogenism, and of course, ovaries with multiple cysts. It's a leading cause of infertility and is often associated with, this is the problem, metabolic dysfunction, which has insulin resistance, obesity, and an increased risk of type 2 diabetes and cardiovascular disease. Worldwide, we see PCOS affects 5 to 20% women, but in India, we have it in 1 in every 5 women too. So I wanted to bring out a case before I started to talk about both PCOS and insulin resistance. And I hope at the end of this talk, the purpose of my talk is basically that you guys are very thorough with diagnosis and then how to manage these conditions holistically. So, because both of them require that. So this young girl, 18-year-old, comes to my office with a BMI of obviously 31, very high, frank obesity. Her family history had her mother with type 2 diabetes that happened to her mother at the age of 45. But she also said that her aunt had PCOS, younger than her mother, and did not have children. So she had irregular menstrual cycles since she had achieved menarche at 13. And she usually has her periods, she doesn't know, sometimes at 3 months, sometimes at 2 months. I could see excessive facial and body hair growth. And she had seen that for the last 2 years. She's had acne, which is resistant to standard regimens. recent weight gain of 10 kgs over the past years, and has fatigue and increased appetite. In my examination, she did have abdominal fat deposition and central obesity. And she had, of course, acanthosis nigrans, which are dark velvety patches, which were at the neck and the underarms, which were suggestive to me that she might have IR or insulin resistance. She had acne on the face and upper back, and these were all moderate to severe acne. And she had mild hirsutism and mild to moderate, we'll say, because the score was around 10, the Ferryman-Galway score of 10, which is usually mild to moderate. So she had elevated total testosterone levels, and she had a higher LH to FSH ratio. And this I did, especially the LH FSH ratio, 4th to 7th day of her cycle. Fasting blood glucose levels were 105. So it was an impaired fasting glucose. Fasting insulin was actually 18, which was elevated. And her HOMA-IR was 3, which indicated that she had insulin resistance. Well, having a fasting insulin of 18 itself means that you have IR. Her ultrasound also showed enlarged ovaries with multiple small follicles arranged in the periphery, consistent with the polycystic ovarian morphology. So what is really PCOS? PCOS is a complex multifactorial disorder influenced by genetic, environmental, and lifestyle factors. And the key mechanisms for PCOS, it could be a hormonal imbalance, increased LH, you could see increased LH secretion disrupts the ovarian function, and as a result of it, there is anovulation. There is a decreased FSH, which impairs maturation of the follicles and instead results in multiple small ovarian follicles. Insulin resistance and hyperinsulinemia is what it can result also. It shows insulin resistance in peripheral tissues leads to compensatory hyperinsulinemia, which stimulates, again, I have shown a diagram later, excess androgen production from the ovaries. And this leads to hirsutism because the excess androgen will lead to excess hair growth, can also lead to acne, and can also lead to alopecia. So I also want all of you to not just look at acanthosis nigrans or acne, but hirsutism and alopecia, which are so contradictory. So you have male pattern balding in these women, but you see hair on the chin, hair on the upper lip, and other areas of the body. There is chronic low-grade inflammation. I have usually seen these people and I check them that the CRPs are elevated. I don't commonly do TNF alpha or interleukin 6, but there have been studies which say that those levels are also affected. And as you know, that having higher inflammation leads to further metabolic dysfunction and leads to further worsening of insulin resistance. Also, there is a disrupted adipokine signaling. So, as obesity, we by now know, exacerbates PCOS symptoms with there's higher leptin and decreased adiponectin. So there is less satiety, there is more craving. Just the disbalance between leptin and adiponectin levels also affects ovulation and, of course, glucose metabolism. So it should be very important just to look at in the pathophysiology to remember that there is going to be a LH-FSH ratio elevated, and when LH is going to be high, it will lead to anovulation, and because FSH is smaller, there will be smaller follicles. Insulin resistance, hyperinsulinemia, hirsutism, acne, alopecia, inflammatory markers like CRP, TNF alpha, And remember that there is also a disrupted adipokine signaling. So now we come to the types of PCOS. And I just try to look at like something more than what I've usually thought of it. But if you look at the different phenotypes in which it presents, the most common is the insulin resistance PCOS, in which there'll be obesity, metabolic syndrome, and mostly abdominal obesity. And sometimes there is prediabetes and type 2 diabetes. This is the one that really benefits with lifestyle changes and insulin sensitizing drugs like metformin. Then there is an inflammatory PCOS. It's characterized by chronic inflammation, which further causes hormonal imbalance and metabolic dysfunction. These people can actually have normal weight, but elevated inflammatory markers. But I've seen this in a lot of people with higher BMI also. Then there is this adrenal PCOS. There's androgen excess, and this is primarily driven by the adrenal dysfunction rather than ovarian dysfunction. Please remember that. Often presents with high DHEAS levels, but the ovarian androgens are absolutely normal. So you need to check this, because this is where the adrenal PCOS comes. This is a very important point. There is an androgen excess coming from the adrenal origin and not from the ovarian. So the ovarian part looks all normal, but if you had to check the DHEAS levels, they will be high. And then there is PCOS in women who've used the pill for a long time. This is just a rebound that the body does after the estrogen progesterone combination oral contraceptives are stopped. There is a rebound androgen excess, and that is called the post-pill PCOS. I'm going to go one more time just for everybody to understand that. Think about the most common insulin resistance kind. You'll probably find overweight, obesity, metabolic dysfunction, prediabetes, diabetes. It responds very well to metformin and diet and exercise. Inflammatory PCOS, you'll see CRPs are high and weight might be normal or high. And again, lifestyle works very well for this. Adrenal PCOS is check the high DHEAS levels. And in some cases, you need to also check the 17 alpha hydroxy progesterone level, and that's because you need to make sure that this is not we have to make sure that we are seriously looking at the right. So if you look here, if you diagnose PCOS, always think of the Rotterdam criteria, and you need only 2 out of the 3. You don't have to have all 3. So irregular or absent ovulation, less than 8 cycles is called oligomenorrhea. Absence of periods for more than 3 months starts to become amenorrhea. Hyperandrogenism, hirsutism, acne, androgenic alopecia, and you can have higher testosterone or DHEAS levels. Polycystic ovaries on ultrasound, if you find more than 12 small antral follicles per ovary, 2 to 9 mm in size, or your ovarian volume is more than 10 centimeter cube. So you have to think about these points, look at it. 2 out of 3 criteria. So one criteria is ovulation or irregular menstruation. Then the second criteria is anything that represents hyperandrogenism. And the third criteria would be your ultrasound. So suppose you had a woman with infrequent menstruation, irregular, no signs of androgenism, testosterone level was normal, DHEAS was level, no hirsutism, acne or anything, but has ovarian volume of more than 10 centimeter cube or has more than 12 small antral follicles, she has PCOS. Or you might have a patient with irregular cycles and all signs of hyperandrogenism, but normal ultrasound. Or you can have a patient with hyperandrogenism and ovarian cysts, but a normal menstrual cycle. So there are so many. Please classify that patient into these three criteria. The minute you see that they might have PCOS, ovulation or absent ovulation or irregular cycles, then signs of androgenism or polycystic ovaries on ultrasound. You should also test, as we talked about, fasting insulin levels and glucose, lipid profile, thyroid function tests, of course, and 17-hydroxyprogesterone to exclude congenital adrenal hyperplasia. I hope till now everything is clear. How do you manage PCOS? And I've written a holistic approach because I want everybody to understand that that's what it is. It's a lifelong condition and should be managed very precise, very personalized or individualized based on symptoms, metabolic risks, and reproductive goals. Since every woman experiences it differently, a very precise treatment is crucial for symptom relief and metabolic health. The primary focus is on lifestyle modification, hormonal regulation, and insulin sensitization. Again, lifestyle modification, hormonal regulation, and insulin sensitization to improve both metabolic and reproductive health. So for all types of PCOS, lifestyle changes are the cornerstone of management, particularly in insulin resistance PCOS. So let's go on the lifestyle modification, and I'm very, very particular about this. A patient should be well counseled on a low glycemic index diet, and this will regulate the sugar and insulin levels. High fiber foods, grains, legumes, vegetables, whatever you can to prevent insulin spikes. Healthy fats, omega-3 from fish, flaxseed, nuts reduce inflammation. Balanced protein intake, lean proteins, tofu, paneer, lentils help get muscle mass, which also helps in glucose metabolism. And reduce processed carbs and sugars, avoid refined sugars, sodas, junk foods to prevent blood sugar fluctuations. I know something here would be also IF, and we can talk about that separately in our discussions, but definitely helps certain group of people in reducing their insulin levels. These are not lean PCOS people, but definitely people with overweight or obese PCOS. Exercise that helps. Strength training helps improve insulin sensitivity and reduces visceral fat. Cardio, like walking, swimming, cycling, jumping, whatever, skipping, aids weight loss and hormonal balance. And there is, of course, HIIT, which is the high intensity interval training. It's very much effective in reducing insulin resistance. Very importantly, stress management is very, very, very important. Mindfulness in yoga, it lowers cortisol, and which benefits insulin, sorry, not versus, that's my bad. It improves insulin resistance. Adequate sleep, which is poor sleep, disrupts metabolic and hormonal balance. So if your sleep is not good, it is going to affect your metabolic and hormonal balance. So medications for symptom management, depending on symptoms and patient goals, various medications can be prescribed. You can give combination oral contraceptives. You can give cyclic progesterone therapies. We all know that helps induce periods in women who can't take the oral contraceptives. You can, for fertility, ovulation inductions, and I know that most practitioners or physicians don't do this. We all mostly send them to their OB or gynecologists. Letrozoles and clomiphene citrate. Metformin is given to insulin resistance PCOS to improve ovulation very early on. So the first one was for irregular periods and ovulation issues, including fertility. The second medications are for insulin resistance and metabolic issues. Metformin, of course, improves insulin sensitivity and lowers testosterone levels. And it also helps regulate cycles and may aid weight loss. And there are many, many studies on myo-inositol. And I don't know if D-Chiro is available in India, but myo-inositol is available openly in India, and it has helped a lot of my patients. It's a natural insulin sensitizer. It improves ovulation and metabolic health, and it has helped so many young girls that I've used it on. Now, medications for hyperandrogenism, which is hirsutism, acne, hair loss, spironolactone, flutamide, finasteride. These reduce excess hair growth and acne. And now they have this cream, eflornithine cream, which reduces facial hair growth. And of course, laser hair removal and electrolysis, but mostly laser hair removal now is for persistent hirsutism. So I think this is the option for mainly, this was not for the acne and hair loss, I guess, but for hirsutism. So acne, again, I would send them to dermatologists, but oral contraceptives, when they are used in patients, the acne improves tremendously. And but in most cases, using a cosmetological approach to acne is also very important. In some cases, minoxidil, some cases doxycycline, some cases azithromycin, some cases vitamin A, retinol. It's very important to acne has various ways. Hair loss, making sure that the thyroid is normal, making sure that the biotin supplements are ongoing, making sure that, there are many cosmetological approaches to hair loss, which I don't want to go on this platform. Fertility management, if you get them through lifestyle or through metformin, weight loss of 5 to 10% reduction can restore ovulation naturally. And of course, we know that letrozole, Clomid, or gonadotropins, and of course, IVF. So how do you manage long-term health risks? Since PCOS is associated with increased risk of diabetes, cardiovascular disease, and endometrial cancer, a regular monitoring is essential. Annual screening for diabetes with A1C, fasting glucose, and checking for fasting insulin is important. Lipid profile and blood pressure checks to prevent cardiovascular disease. Measuring endometrial thickness via ultrasound to monitor for hyperplasia is also important. So remember, in your management, follow-up is also needed. So counseling the patient early on is very important. What supplements do I give to people with PCOS? I make sure their vitamin D levels are normal. I always give them omega-3 because they have inflammation usually higher. Myo-inositol is something that I use very, very easily. And magnesium is something which has also shown benefit with PCOS patients. Actually, so this is what I have about PCOS, and I'm going to go to the insulin resistance. So I wanted to show this diagram which sort of brings insulin resistance and PCOS together. So the darker green side of the triangle, the upper triangle, is the insulin resistance part, and the lower lighter part of the diagram has more ovarian or the PCOS part. So if you look here, there are multiple follicles in that ovary, and if you see that the LH ratio is increased, there's an abnormal gonadotropin releasing hormone pulsation. Hyperandrogenism is what happens, which sort of pressurizes the pancreas to release further insulin. So the insulin level rises. It does not enter the muscle or the liver well because the insulin resistance of liver and muscle come into action. There is also adipocyte dysfunction, and that's where the leptin adipokinin levels change. And then there is visceral obesity from all of this around the abdomen, and then the liver has fatty liver. There's a decreased sex hormone binding globulin from the liver because of its metabolic dysfunction, and which further contributes to the hyperandrogenism, which further contributes to the ovarian follicle and the LHFSH and the abnormal gonadotropic releasing hormone pulsation, ovarian dysfunction, PCOS, abnormal ovarian function, pituitary hyperthyroidism, all of this. So if you see, the second part of my topic is basically shows you how interrelated these two things are. And when I was offered either topic, I said I can't do either because they are together and they have to be discussed together. It's very important to, when we talk about PCOS and the types of PCOS, and when we say the most common type of PCOS is the insulin resistance PCOS, we need to discuss insulin resistance because let me tell you that they are Batman and Robin. You cannot separate them today. So let's go to the next topic, which is the insulin resistance. So insulin resistance, again, is a metabolic condition, and the body cells are less responsive to insulin. There are elevated blood sugar levels. As a result, the pancreas wants to compensate for these elevated blood sugar levels and wants to secrete more insulin. This leads to hyperinsulinemia or higher insulin blood. Over time, this contributes to prediabetes, type 2 diabetes, further obesity by further obesity, adipocyte dysfunction, obesity, and metabolic syndrome. So I think in today's time, insulin resistance has become a very common word, and I really love it because there is so much information out there on what foods cause insulin resistance, how weight gain causes insulin resistance. And I see a common person coming to my office, and I'm sure you all are also experiencing that, and saying, how do I measure my insulin resistance? How do I know that how bad is it? Is it mild, moderate, severe? And it's really a joy to know that everybody's trying to understand insulin resistance, because I really feel that this is something that we all need to understand very deeply. So what contributes to insulin resistance? Yes, of course, genetics has a role. When we have obesity and we have a lot of visceral fat, abdominal fat releases inflammatory markers which work on the pancreas, which interfere with the glucose metabolism, rise, pancreas feels pressurized to release more insulin. Physical inactivity, muscles don't use the glucose sits in the blood vessel, further putting pressure on the pancreas to release more insulin. When the diets are high in processed carbs and sugar, it leads to chronically high insulin levels because constantly the pancreas is working to release something to digest those high in processed carbs and sugars. Of course, stress and poor sleep elevates cortisol, which worsens insulin resistance. So remember that it's very important that we know what factors contribute, because if we know the factors that contribute, we can work against those factors. So it's very important to know this. So how does it develop insulin resistance? So normally insulin binds to receptors on muscle, liver, fat cells, and allowing glucose to enter those cells. And in insulin resistance, the signaling is defective. Number two, the pancreas is compensating by producing more and more insulin so that some glucose can get forced into these cells. So there is higher insulin secretion. Then there is liver dysfunction. The liver overproduces glucose. There is breakdown, there's gluconeogenesis, because it is misinterpreting the insulin signals. It's not able to take the insulin signal to make glycogen, which is stored form of the glucose. It reads the dysfunctional insulin as brake insulin. So it actually overproduces more glucose. There's fat accumulation and inflammation. Excess visceral fat releases, so wherever there is more abdominal obesity, it releases inflammatory cytokines like TNF-alpha, IL-6. This further disrupts insulin action. Beta cell exhaustions. Over time, your pancreas fails to keep up with insulin demands, and then the insulin secretion gets affected. And this leads to frank diabetes. I think I have really tried to explain your pathophysiology at every level possible. And I hope we will all make sure that we are very aware of the various mechanisms of insulin resistance pathophysiology. And then how does PCOS worsen insulin resistance? We've seen that diagram. In PCOS, as we saw, higher androgen levels have been associated with reduced insulin sensitivity, leading to diminished ability of body cells to respond to insulin effectively. This reduction in insulin sensitivity necessitates increased insulin production by the pancreas. We all know that. So higher insulin levels in the blood. Adipose tissue, especially when excessive adipose tissue is there, releases various substances that can interfere with insulin signaling pathways, leading to decreased insulin sensitivity. PCOS is often associated with chronic low-grade inflammation and increased oxidative stress, both of which can impair insulin signaling and exacerbate insulin resistance. So, everything comes down to how related these two syndromes are. How do you manage insulin resistance? Very similar to PCOS. Basically, low carb, high fiber diet, healthy fats, adequate protein intake, reduce processed sugar and refined carbs. Here, I will always say, look at IF, because now, again, people do odd things with IF. So it's very, very important to stay in the circadian rhythm, because I don't want to get into deeper aspects, but circadian rhythms are very, very important to regulate our body's metabolism and hormonal balances. So it's very important for the insulin, for the IF or intermittent fast to stay within the circadian rhythm. You cannot have somebody fast till 2 in the afternoon and eat from 2 to 10. That would be terrible. That would be the time when the insulin resistance is highest in the body. But if the patient could end eating at 4 in the afternoon or 5 or 6 and not eat till 10 in the morning, is the best kind of IF if possible. I do believe that even a 12-hour clean body without any calories can lead to a lot of benefits with insulin levels. Strength training, again, is known to improve insulin sensitivity as muscles just suck up the glucose from your blood. Even brisk exercises and HIIT enhances it. Post-meal walks can reduce blood sugar spikes. Very important. Again, weight management, losing 5 to 10% of body weight improves insulin sensitivity. Sleep and stress management, quality sleep at the right time. 7 to 8 hours of uninterrupted sleep early in the night is when your hormonal balances are perfect. People who sleep from 12 to 8 lose some benefit, 10 to 6 more beneficial, because it's the 10 to 2 when all your growth hormones and the balance of all the other hormones is the best when you're in deep sleep. So sleeping at the right time. Meditation helps, deep breathing, yoga, everything helps. In IR, metformin, of course. And now we have GLP-1 receptor agonists, and all of you have heard of Mounjaro hitting our market and starting as of April 1st, and helps in weight loss and, of course, insulin regulation. Inositol, berberine, omega-3 magnesium. So I'll go back to the case A that I mentioned to you, that 18-year-old girl with a BMI of 31 with family history of type 2 diabetes in her mother at 45. She had high testosterone levels. Um, uh, she had multiple follicles. She met all criteria. She was very irregular cyclic. This case exemplifies the bidirectional relationship between PCOS and IR. The patient's obesity and family history predisposes her to insulin resistance, and this contributes to hyperinsulinemia. Elevated insulin levels can stimulate ovarian androgen production, exacerbating hyperandrogenic symptoms and such as hirsutism and acne. And conversely, the hormonal imbalance inherent in PCOS can further impair insulin sensitivity, creating a vicious cycle that perpetuates both conditions. So, how did I manage that case? So, I put the patient on fiber, lean protein, complex carb, calorie restriction of 1200 kilocalorie diet. I also gave her just a 12-hour fast every night from 6 to morning 6 o'clock. She made it 14 hours, but that really helped her. I gave her a 60-minute daily exercise routine, 3 days cardio, 3 days strength and conditioning. I put her on metformin 500 twice a day for 3 months and advised to start combination OCs for cycle regulation, which she did not, and her mild hyperandrogenism. And I wanted her to see me back in 3 months with sugar levels, weight, regular measurements, follow up on if cycles got regulated or she would be referred to gynecology. I also gave her my inositol. So the outcome was such that with my inositol, with metformin, with her exercise and a 1200 kilocalorie diet and 12 hours of daily low calorie, 12 to 14 hours, it was amazing that she lost about 15 kgs over a year or 12 kgs, something like that. And her cycles got regulated. Her hirsutism did not go and she had to get some laser done, but she did not take oral contraceptives. So I think that's what happened with that case. But it came out, the main thing that came to me in that case was, and she took metformin only for 3 months. So my whole thing was that how did that woman get better? How did this 18-year-old, by losing weight, by being strict on her calorie diet, by not eating at least on the times that your insulin resistance are very high. So what does it come down to? It is, I feel, even though she had a genetic predisposition, even though she had all 3 signs, and yes, her hirsutism did not improve, her skin also got clear as she lost weight. So I think somewhere lifestyle, again, according to me, is the most important part of your entire PCOS management and IR, insulin resistance management. Her sugar level stayed good. She never became pre-diabetic. Her fasting insulin level, I think I mentioned it was 18. On a follow-up at 6 months, it was down to about, and she had taken by that time 3 months of metformin also, was down to 7. Some points to ponder as we talk about it. Polycystic ovarian syndrome and insulin resistance are deeply interconnected. And at the end, I'm making this all about the first type of polycystic ovarian syndrome, which is the insulin resistance PCOS, because that's what's most commonly seen. And insulin resistance plays a key role in the hormonal imbalances seen in the PCOS. Insulin resistance drives excess insulin production, which stimulates androgen production. It leads to irregular menstrual cycles, weight gain, and other metabolic disturbances. Conversely, in PCOS, higher androgen levels have been associated with reduced insulin sensitivity, contributing to worsening insulin resistance. So if you see, you can't get, it's a cycle, and a cycle. So this bi-directional relationship underscores the importance of comprehensive management strategies that address both hormonal and metabolic aspects of PCOS and IR to effectively break the cycle. Thank you very much.
Thank you.
So, yeah, go ahead.
No, ma'am, please. Continue, ma'am.
I'm saying there's a question I can read which says, shall we recommend low calorie 1200 to lean PCOS? No. First, you have to know that the lean PCOS, do they even have IR? So most lean PCOS, as I've explained, probably don't even have insulin resistance. They probably are hyperandrogenic to begin with, and as a result of it, they would probably not have um, uh, IR to begin with. So giving them a low calorie diet would not serve the purpose. They would further lose muscle, which is not good for the glucose metabolism.
So for this wonderful session, we actually do have a lot of questions in the comment box, and we can take them one by one. I think one of the earlier questions that we had, and I am highlighting it for you on the screen. Dr. Gautam says, is every case associated with menorrhea of PCOS?
No, not at all.
Another question from Dr. Gautam was how to manage sterility in PCOD.
So I have already sort of, so basically what it means is how do you improve ovulation in PCOS, and which will improve fertility. So basically, as I've already mentioned, and in the presentation, you will have to look at various ways for reduction of weight is one of the most important aspect. Actually, again, lifestyle. I'll keep repeating that. So it's very, very important for you to focus on the weight reduction, and because the woman starts to ovulate better, the ovarian hormone balances become better if the patients lose weight. So if they lose up to 10% of their body weight, they might automatically start. Otherwise, you might use, as I've put, ovulatory agents. You have different kinds, and they're all, we don't use them as we are as physicians or GPs, but yeah, gynecologists do that, and we can stimulate. And the third line we all know is IVF and or IUI. So I think that is what is the way we go with that. And there are agents for ovulation stimulation. But before that, if you had the patient lose weight and take metformin, the chances of ovulations are higher.
So next question says, can PCOS be independent of metabolic disorders?
Yes. There are PCOS of various types, as I explained. There's PCOS with IR, which has metabolic dysfunction. Then there is PCOS with inflammation, which can also be associated to metabolic. But then there's PCOS, which is just an adrenaline origin, which has nothing to do with at all with metabolic dysfunction. It comes from adrenal origin, and it does not come from the ovulatory. So there, yes, you are very right. It can be independent of any metabolic disorders. Very infrequently, but yes.
So next, this is the criteria of PCOD different in secretory and proliferative phase.
Absolutely. So it's very important to understand PCOS, and I will recommend that the best time of PCOS is after the cycle. So when you're testing a patient, do it from 4th to 7th day of the cycle, and that those are the values which are actually expressed in all your comparatives and references. It is so much better to do within the 4th to 7th day of a patient's, including their ultrasound.
Next question from Dr. Shri, lifestyle measures to overcome insulin resistance. I think we've already discussed, but if you could just go through it again, ma'am.
Are anytime. This is my favorite topic. Thank you for asking again. But of course, lifestyle, as I said, is number one is diet. So, fiber, lean protein, low, absolutely avoid simple carbs, more complex carbs, smaller portions. Make sure that there is at least a 12-hour gap from dinner to breakfast, minimum of that. And at the right hours, it shouldn't be at 11 in the night. From 7 p.m. onwards, our insulin resistance becomes worse in our body, because at that time, our pituitary is secreting melatonin, and our body is getting ready to close itself down. Growth hormones are coming in. We need to renew ourselves. So insulin is not working. So if you're putting calories or you're putting carbs after 7:30, be prepared that the insulin levels, it's going to just stay in your body. And the pancreas will keep secreting the insulin, which will not get used up. And that's where the insulin resistance becomes much worse. So one of the most important steps for insulin resistance is no calorie after 7 p.m. One of the most important. Then it comes is diet, exercise, which would strengthen conditioning, helps insulin sensitivity, Cardios, to break down your workout, each day 60-minute workout, one day cardio, one day strength and conditioning, or one day yoga, meditation, yoga, all of that thing helps. So basically, losing weight by the right way helps overcome insulin resistance. Sleep is very important, and stress reduction is also very important.
So moving on to your next question from Dr. Thomas. What is meant by reduced insulin sensitivity?
It's just the other side of the coin. One side is insulin resistance, and you turn the coin and it's insulin sensitivity. It just means insulin resistance. So reduced insulin sensitivity has come down. What has increased? Insulin resistance. So it's just the other side of the coin.
Right, ma'am. So moving on to the next question. So Dr. Patwari says, in lean PCOS, what diet and exercise do we uh, advise as they're not obese and there's no belly fat?
Yeah, so exactly. So I was mainly mentioning diet and exercise for PCOS with IR. But remember that even reduction of stress and endorphin secretion from moderate exercise, which could be yoga, which could be Pilates, which could be stretching exercises, or some therabands or isometric exercises, which don't burn calories, and your patients don't lose further weight, but they develop more muscle. Plus, they also have release of endorphins, which really helps them do the hormonal balance. So, exercise is, you can say, is for weight loss, but exercise is also for well-being. It is also for getting the happy hormone increased in our system. And it's very important to give it to, because there is a baseline inflammation even in these patients. So it's very important to advise some form of exercise which helps them heal.
So next, Dr. Mishra says, is menorrhagia possible in PCOS patient?
If there is endometrial hyperplasia in PCOS patients, it can lead to menorrhagia, yes.
Next, Dr. Thomas says another question. Blood investigation and insulin resistance and the findings. So how do we correlate?
So you will do basically, if I were very, very simple, let's not make it complicated. We should do fasting insulin, we should do A1C, and you should do fasting sugar, fasting insulin, and A1C. I'm not even going to ask you to go into the index of HOMA-IR calculations. Listen, if your patients who should be fasting, anybody who's fasting, my fasting insulin should be less than 5 because there is no sugar in my system. I'm fasted for maybe 8 or 10 or 12 hours for the insulin to be secreted. The minute insulin starts to cross 7, the patient is getting into, so 7 to 10, mild insulin resistance, 10 to 15, moderate insulin resistance, above 15, high insulin resistance. That's how you look at insulin resistance.
So Dr. Patwari says there is insulin resistance in body, but paradox at level of ovary. How?
Don't understand the question. Sorry.
Dr. Patwari, if you could just
explain.
Post your question again. Till then, we can maybe go ahead with the next question. So Dr. Madhuri says, does impregnated IUDs lead to PCOS, and does sleeping for long hours affect the ovulation?
Impregnated? What does that mean?
IUD.
Impregnated IUD? Oh, you mean inserted IUD? Oh, so sorry. Okay, so IUD inside a woman cause PCOS? No. And the second part of the question was
Sleeping for long hours affect the ovulation. Yeah.
I haven't read anything about sleeping long hours, but in general, we should not be sleeping long hours. Why are we sleeping long hours? There should be a limitation. 7 to 8 hours of uninterrupted sleep is what is advised. If we are sleeping more than that, let's find reasons for that sleep. Is the thyroid not active? Is there something inflammatory markers in the body high? Why are we fatigued? Why are we sleeping more? Is there sleep apnea? There is many reasons for us to ask ourselves why are we sleeping excess. Excess sleeping will generate slower metabolism, will generate fat collection. So yes, we should not sleep more than 7 to 8 hours as adults.
So next, Dr. Banerjee asks, how do I understand whether the PCOS patient has insulin resistance or not?
Okay, so again, let's look at what I've explained. PCOS patient with irregular cycles can have any of the three Rotterdam criteria, which would be irregular cycle, anovulation, or there could be all signs of hyperandrogenism on the ultrasound. Now, you have seen that patient and you are now wondering, is it the type of PCOS, is the insulin resistance PCOS? The patient has to meet certain criteria, okay? And that would be mainly obesity or central obesity. If the patient has central obesity, you can assume that they might have insulin resistance. And if you assume that, the blood test that you have to order is, you can order fasting insulin just to check if the insulin levels are higher than what it should be at fasting. And if you want to do a HOMA-IR, some labs even calculate and give you an index, which is basically what it is. And they sometimes even take out the beta cell function, which is C-peptide, and add it to the HOMA-IR and produce a index for you. So I hope you understand that for checking on your PCOS patients, if they have insulin resistance, you need to check fasting insulin level and then look at the level.
So next, Dr. Afsha asks, will you prescribe insulin sensitizers based on blood reports or for every PCOS irrespective of the blood tests?
No, I need to know if they have insulin resistance or not. You cannot give insulin sensitizers until somebody has insulin resistance.
So next, Dr. Uma says, ma'am, the 1200 calorie diet, will it depend on the weight of the patient or irrespective of the weight, should be strictly on
No,
1200 calories?
it was only for overweight PCOS with IR. It is not for lean PCOS, the 1200 calories.
So we've had a few questions on inositol, so I'm just addressing it together. What is the dose and duration? And also the mechanism of action or any side effects that we need to watch for?
So no, so I haven't seen any side effects over the time that I've used. It basically regulates glucose metabolism through muscle activity and through liver. It's a natural product, so don't ask me the dose. I'm sorry. They come in sachets, and the dose that you give to the patient is one sachet a day. Sometimes I have seen gynecologists prescribe it twice a day. Also, I give once a day, and I don't know what is the exact milligram that you can probably check yourself, but they usually come as sachets and not a tablet. And you dissolve and you take them, and basically both work at the liver level and at the level of the glucose metabolism at the muscle level, and helps in glucose metabolism.
So Dr. Vikas says, how do we encourage female patients for exercise without having any PCOD to prevent chances of PCOD in future? If you'd like to share anything, ma'am.
Yes, Dr. Vikas, that's a very good question. See, I feel that it has to start very young. Yeah, so you have a daughter, you have family members. So I think somewhere affluence in India brought PCOS to us. Processed foods brought PCOS to us. Affluence meant we could have cold, drinks and sodas and chip packets, and just order from Swiggy or whatever. It is just terrible how our society is utilizing the money and the affluence that we have. And I think the byproduct of that is going to be PCOS with IR, and it's going to be type 2 diabetes, infertility. We don't realize what happens. So, where should this all change, Dr. Vikas? Very good question. It should change in your home. It should change in what you buy in your groceries. It should change in daily dining table talk in family members. Eating on time should be, how many doctors who are sitting here eat on time? How many doctors make sure before their evening clinic starts, they are done with your dinner? When we do something, we will pass it on to society, be it our children, be it our patients, be whoever that is. So, according to me, if a PCOS does not need to develop, diet is a very big part from a very young age to be right. It has to have, I'm not saying you don't give kids an ice cream, but you give them once a month as a reward when they go out. You don't fill your freezers with ice cream. That is your choice. I'm not saying kids cannot have pizza. They can have it once a month when you get out. You don't have to fill or order from Swiggy pizzas all the time just because they're children and they can eat anything. So it's very important to look at that aspect. Now, also, you have to, when the parents come with the children, it is a advice given to the whole family. Go for walks together. Just get into a cycling mode together. Do something fun activity, not go and sit in a movie theater or eat in a restaurant. Go do a picnic or walk or see a monument or do something where your physical activity is very important. Parents have to do it before they tell the child to do it. So I think, I'm sorry, I'm going into a very societal answer, but there is no other way we all can bring a change until we bring our change into our thought, our action, including us doctors. All of us have to be responsible and think where we are going with our own health, and then probably be able to, I'm sorry, inspire.
Yeah. There's another question that was coming up quite commonly, and I think people do have some confusion. Is there any difference between PCOS and PCOD?
No, they're the same things. Absolute single line. Don't get confused.
Right. So next from Dr. Shah, Dr. Shah is asking about magnesium, if it has any role in combating insulin resistance. Also, which magnesium salt is preferred in such cases?
I don't have any direct correlation, doctor, of Dr. Shah, for magnesium and insulin resistance, but magnesium has so many different roles in the body if you read about it. It really does help our hormones indirectly. It causes relaxation of arterial walls. It causes muscle spasms to get better. It is just one of the best way of, it helps glucose pass across muscle into the blood. It's got a lot of great. So in a way, it has a role in metabolic improvement. The best salt is glycinate. And I think you have to always look at a supplement and see what is the bioavailability. So if you read a supplement and it says 500 milligrams, but you slowly bioavailability 60 milligrams. So please look at a higher bioavailable vitamin, and glycinate can be taken up to bioavailable milligram volume, not what is the dose of the drug, is up to, I think, 200 to 250 bioavailable magnesium glycinate can be taken daily.
So, ma'am, in the interest of time, is it okay if we take the last two questions for tonight?
Okay, sure.
So next is again from Dr. Shah. How do we correlate fasting glucose and fasting insulin to decide insulin resistance and severity of insulin resistance?
Fasting insulin is showing you impaired glucose metabolism. That means patient is becoming pre-diabetic. Let's not associate that, and that is coming from the insulin resistance. fasting insulin is giving you a diagnosis that the patient is having insulin resistance. But is it translating to becoming prediabetes or diabetes is through the fasting insulin. I hope that's clear.
So the last question is from Dr. Nath. Which drugs are to be prescribed to an adolescent girl with PCOS to reduce the hirsutism and obesity?
So, drugs for an adolescent girl is, I don't have an answer for that, except that if you get her to lose weight is the most important part. Um, for hirsutism, you will have to work with to look at it because there are medications that help. Spironolactone helps. I'm not sure how much of it can be given to a person under 18 years of age. So there's not much you can do for under 18, but of course, taking away the hair by laser can happen for sure. For acne, you have various ways to treat a adolescent child. Um, Obesity, there is none of the drugs are approved for under 18. Trust me, none of the GLP-1s, none of the Monjaros or the Ozempics, nothing is under 18. So we have to understand that none of these drugs are under 18. And we should not actually, I really believe under 18, if you really work on their psyche and get them into a good program where they can lose weight and work with a coach and understand very early on that their diet and their epigenetics, the environment they've created around themselves, is actually responsible for it worsening very fast. These children show amazing growth, confidence, and good results at the end of it. So let's stay away from the drugs here.
So, ma'am, with this, we have come to the end of the Q&A. I'd like to thank you for taking all the questions very patiently. And thank you once again, ma'am, for this wonderful session. It was really lovely to have you back. And also, I would like to mention that there's some lovely feedback about the session in the chat box if you'd like to go through it. And thank you once again, ma'am. Really hoping to see more of you with us. Thank you once again.
Thank you, everybody, for joining. I really appreciate all the wonderful questions. And I'm very happy that I could do this. Thank you.
Thank you, ma'am.